I want to welcome Dr. Lindsay Shroyer and also Dr. Kelly Hernandez.
Thank you. Thank you for putting on such a great presentation this morning, putting together such a great program for everyone. Thank you all for being here. We really appreciate your attention, and this is something we're really passionate about, and we feel like it's worthwhile sharing. These are patients you're seeing in your office too, so that is why we're here. We don't have any disclosures. In the US, by 2030, there's estimated to be about 78 million people over the age of 65. Humans are living longer, our patients are aging. We are not aging, but our patients are certainly aging. So these are people you're gonna see in your office. You're impacted by hearing loss. Age-related hearing loss, also called presbycusis, is one of the most common conditions affecting older adults. It most often occurs in both ears. You get to take both ears everywhere you go for most people. They don't get to leave one at home protecting one for later use. Both ears go with them, so it's exposed to noise, it's exposed to all of the elements. Hearing loss in this population does tend to be gradual. I know we've talked about some sudden hearing loss earlier in our earlier presentations, but this tends to be more gradual. These people may not even realize that they are having difficulty. Not many times they're gonna come in and say, well, you know what, my wife was right. I'm not hearing very well, so let's fix that. Oftentimes it is the high frequencies that tend to go first. So you may have them complain, well, everybody just seems to be mumbling. It's not that I'm not hearing well, it's that they're mumbling. Or they're turning up the television volume and other people are complaining about that. Here's a nice little picture that, again, people are living longer. We're seeing ages increase, and that's worldwide. There are about 466 million people with disabling hearing loss in the world. And the World Health Organization defines that as thresholds of 40 decibels and greater. So that's what we would consider a moderate or greater hearing loss. 432 million of those people are adults. It's not just the adult population that has hearing loss. We see kiddos every single day that have hearing loss that are being managed as well. 1 in 3 adults age 65 and older are impacted by this hearing loss. Again, it's not complete deafness. It's not necessarily profound hearing loss. They're considering disabled hearing loss 40 decibels and above. These numbers are projected to grow, perhaps even up to 630 million people by the year 2030. And then again, over the age of 64, 65, you're gonna see several people who are running into perhaps these untreated hearing loss issues. The Cleveland Clinic has a nice little picture here so that you can see again that hearing loss is not just isolated to certain populations of age. It is impacting people, kiddos, newborns under the age of 18 as well. And again, we see referrals from newborn hearing screens, we see failed school screenings, we see failed pediatrician office screenings, so it really impacts the whole population. So why are we talking about this? How is this impacting your practices? How is it impacting what we can do to help? If a patient has trouble hearing you, they may not be complying with your recommendations. It may not be intentional, but if they're having difficulty deciphering and understanding what you're saying, they may not stop and clarify. So they may not be able to comply with the recommendations that you're making. They may have difficulty hearing alerting devices, hearing warning signs, knowing that the car is coming down the street while they're walking. So those all can impact safety things. They may not hear on the phone. They may not hear the doorbell. They may not hear the smoke alarm. Again, all safety concerns. They also may be secluding themselves. They may not feel comfortable going out to lunch and spending time with their family because they're having more difficulty understanding those conversations. So that can lead to feelings of isolation. They may be depressed. They may be running into things that, they just don't feel good, but they're making excuses as to why they don't go to those social situations anymore because they don't feel confident in that area. Also, there's tons of literature out and lots of research being done about how this is related to cognitive decline. We are not saying if you have hearing loss that you are going to have dementia. That is certainly not what we are saying. But hearing loss and the side effects of that do impact cognitive function. And so that's something that's being delved into quite a bit with the research now. So just in terms of cognitive ability, you've got executive function, working memory, processing speed, selective attention, sequential reasoning, and lexical knowledge. A couple things I want to touch on here. One is processing speed. We talk about this a lot with our patients after they've been treated for their hearing loss, whether that's hearing aids, cochlear implants, what have you. The ability to process that information doesn't necessarily speed up. We're filling in the gaps that we're treating with that hearing loss, but the brain still needs time to process that information. So that's one of the big things we touch on every day, seeing patients, that the processing speed has slowed down with age. We don't heal as quickly, we don't lose weight as quickly, we don't process things as quickly. So just taking that little extra time to say, this is part of the treatment for the hearing loss. And we're going to talk a little more about cognitive ability. Yeah.
Good morning. So one thing I think it's not necessarily on a slide, but is important to remember for you as a provider, everything is gone to electronic medical records now, and we hear every day from patients how they can't hear their doctors because they're feverishly typing notes as they're talking to the patient. Because processing speed is lower, because they can't hear as clearly, because exam rooms have terrible acoustics, it's super important that when you are talking to your patients that you're looking at them. That way they get a lot of cues from you looking at them in addition to what they're hearing. So let's not get hung up on the word dementia here, because as Lindsay had pointed out, that hearing loss is not causing dementia, but there is research to suggest that 35% of dementia can be prevented due to modifiable factors, and 9% of that may be hearing loss. In a study that was performed by Liu, they found that the greatest cognitive decline was found in people with untreated hearing loss in the 45 to 64-year-old age range. These are working adults. These are people that have complex listening situations throughout their day, whether they're going to meetings or they are in social situations. So it's really important that we are treating them and making sure that they are able to hear in all these situations. And I think this really underscores the importance of doing hearing screenings during a physical. And you can do a hearing screening without physical equipment. There are questionnaires that exist out there that can help lend itself to knowing whether this person may or may not have some difficulties hearing. We don't really know what the correlation is of hearing loss and cognitive decline, but it is a hot topic of research right now, both in the pediatric and the adult range. In pediatrics, it really is impacting their executive function. There is thought that vascularity may play a role in the cognitive decline as well as in the hearing loss. Listening effort is also a factor. If you have hearing loss, this is a big misconception that patients have. They think they hear fine because they're not deaf. And so for some reason, patients don't realize that you can have different degrees of hearing loss, just like with vision. You're not blind or 20/20. There's lots of degradations in between. So if you are having voids in certain sounds of what you hear, it really makes a difference especially if you don't have any additional cues, you're trying to fill in the gaps. And so that's where these visual cues come in. They read lips. They don't intentionally or cognitively read, consciously read lips. It's just something that our brains automatically do. And in doing this, we're outsourcing other parts of our brain. This is another area of research where there's cross-modal reorganization. So if the brain isn't being used for auditory input where it used to be, you're using other parts of the brain for that. So whether it's for focusing attention and trying to get rid of background noise, or you're just like, oh, I caught that first word. What was that? What came after that? And then people get hung up on, oh, okay, I focused so hard on the first part of what was said, now I missed everything that came after that. And then there is research to suggest that intervening for the hearing loss and treating the hearing loss may actually help reverse some of these changes. When people don't hear well, they do tend to isolate themselves socially, and this happens gradually just because the hearing loss happens gradually, and they often don't realize that they're not doing the things that they previously enjoyed doing because they can't hear. Our role as an audiologist is, ABCs is, I think, a popular thing in healthcare. Our ABCs are audibility. We need to make sure that a person can actually hear the sounds. And fitting hearing aids is a little more scientific, I think, than some people would be led to believe. It's not just like, oh, does this sound better or does this sound better? We actually do have some validation measures that we're looking at to see that the treatment that we're providing is doing the intended treatment. And then brain training. With age-related hearing loss in particular, because it onsets so slowly, you are compensating all the time until you can't anymore, so people don't realize that they're compensating. When you suddenly can hear again with hearing aids or cochlear implants, it's kind of shocking. People forget how noisy the world is, whether it's the noise of plastic grocery bags or the clicking of feet down the hall or dogs' nails running across the floor. These are all things that a lot of people with hearing loss forgot made noise or never knew made noise. So we have brain training and there's software. LACE is one of them that people can use, and they sit there at their computer with their hearing device on and just literally train their brain how to hear the information again. And then, of course, compensation strategies. People with hearing loss develop these naturally. We don't expect them to lose them or stop using them because once you have hearing loss, even when it is treated, it is not the same as having normal hearing. So they still will use environmental cues, contextual cues, visual cues, occasionally ask for a repetition. And then most importantly, I think as with any treatment, we have to mold their expectations so that they're realistic to the treatment they're being provided. And a problem with numbers. So according to the Cleveland Clinic, only 14% of physicians were routinely screening patients for hearing loss during a physical. And as Leslie pointed out, people are not generally going to walk into your office and say, you know, my wife says I turn up the TV, I think she might be right. That just isn't going to happen. So you kind of have to pull it out of them. Even if, as I had previously mentioned, don't have the physical means to screen them with a hearing screener, there's paper ones that you can print out from offline. Typically, it takes a patient an average of 7 years to even admit and come to terms with the fact that they have hearing loss before they'll even seek treatment. And according to the Hearing Loss Association of America, 1 in 5 people, so that's 20%, who would benefit from some sort of hearing technology are actually utilizing it. And in 15 years, from 2000 to 2015, the number of Americans with hearing loss has doubled. This is an example of something that you can get from online and just print out, is the hearing handicap inventory for adults. And it just asks some general questions about daily normal activities that people do. How are you hearing in the movies? Are you embarrassed when you meet people because you can't hear the conversation or understand their name? Do you have difficulty hearing in meetings at work? There's a quick questionnaire, and it's like yes, no, sometimes. Scoring it can be a little bit of a challenge because you have to actually assign values to the yes, no sometimes. There is one that's a little simpler that somehow we didn't make it into our slide presentation, but it's by the National Institutes of Health. very similar questions, and it's strictly just yes, no, and if they have a few answers that are yes, then the best thing to do is just refer them for a hearing evaluation. And the worst thing that could happen is, oh my gosh, they have normal hearing and now we have a baseline. You know, that's not a terrible thing. Fighting the stigma is a big thing, especially since that biggest age group of people with hearing loss is in the 45 to 64-year-old range. There's a lot of stigma against hearing aids, but we are actually seeing that get better in these past couple of years. The fact that they have Bluetooth and have rechargeable batteries has brought it right into that age group's wheelhouse, so to speak. And I would say that the biggest misconception that patients give us when we are talking about hearing aids is they are truly thinking about like grandpa's big, giant, Barbie-colored hearing aid that screams and whistles all the time. And that is a lot of people's misconception, and that's just not the way that it is anymore. Additionally, many private insurance companies are actually covering at least a portion of them, if not all, of the cost of hearing aids. Unfortunately, Medicare does not cover any. It's statutorily excluded from Medicare coverage. And so if people have a better understanding of what goes into the cost of hearing aids, because they are very expensive, it's not necessarily just, oh, I want to spend less on a TV, so I'm going to find the cheapest TV at Costco. Hearing aids come along with the expertise and the education and the knowledge of the person fitting it, because a lot of places will just fit a hearing aid and say, oh, here you go, just because you like the way this looks, and does this sound better or does this sound better? Oh, this sounds normal. Well, we don't want it to sound normal. You're not paying money for a hearing aid for things to sound exactly as they do without it. You need to hear better with a hearing aid. So once people understand what is coming along with the expense of that hearing aid, that makes some of that stigma go away as well. And then, making a practice and habit of referring to clinics that do perform best practices when they're testing patients' hearing and fitting them with hearing aids also can help deter negative experiences. So the take-home message from today is that people are living longer. Longer lifespan means greater amount of ailments to manage, and hearing loss is right in there with all of them. Untreated hearing loss leads to depression, social isolation, dependency on other people, frustration, poor quality of life, and cognitive decline can be part of that, and it may be slowed down by treating the hearing loss. So as a primary care provider, you can help get them to a trained professional sooner, and earlier diagnosis and treatment for ongoing management will help lessen the effects of these things. Here is a list of some of our references. Any questions?
Let me give you, we're talking about hearing.
Hi, working in family practice, the cost of hearing aids has been an overwhelming question that I guess I'd just like to have an understanding. Roughly, what are the ranges of hearing aid costs that are associated?
So costs of hearing aids are going to vary quite a bit from one location to another. And one example that we give to patients is they're kind of like cars. You can have a base model or a fully loaded model, and the cost goes up as you become a fully loaded model. So a set of hearing aids can range anywhere from $3,000 to $6,000, with some variations from clinic to clinic. Yeah.
Why is there such a discrepancy between the 45 and the 54-year-olds? What's their main cause of hearing loss?
I can repeat it. She was just asking about why the greater amount of hearing loss for the 45 to 64-year-olds and why it's such a discrepancy from all the other age. I'm sorry,
45 to 50.
Oh, 54. I think it's just not necessarily something that we do have the answer to. Noise can be part of that. Genetics can be part of that, but I don't know that we actually have that answer.
Headphones can cause damage?
Headphones absolutely can cause damage. Our general rule of thumb for people is like if as a parent you can hear what's coming out of it, it probably is too loud. There are, for young children, headphones that can limit the output to 80 dB so that the child is never listening too loud, but headphones absolutely can, yeah. Thank you.
Thank you very much. Great talk. We have